My question is 9-month old baby posted for CTEV correction. What is CTEV? It is a birth defect characterized by twisted foot, high arch in midfoot, forefoot turned inwards, heel turned inwards, hind foot pointed downwards. The cause is usually congenital and it can be associated with other problems such as cerebral palsy or neuromuscular disorders or cardiorespiratory disorders associated with syndromes. Um, m- Coming to the management, the age of the child given is 9 months. The expected weight of the child is about 9 kgs. The problems associated with this baby be- uh, is or my concerns is small age group, that is 9 months. They can be any associated congenital deformities, and uh, the venous access might be difficult, and also about the starvation period. The plan of anesthesia will be according to the surgery procedure planned. Because in earlier stages of CTEV, the procedure planned is usually tendoachilles stenotomy or cast application, and it is usually a day cap procedure. So mostly under we have to secure the IV access, and mostly it can be done under laryngeal mask or local infiltration with analgesics. If operative procedures, which is usually done in later stages of CTEV correction, such as tendon or soft tissue or bony release, in these operative procedures, we usually prefer general anesthesia with caudal anesthesia. And the position associated with this procedures can either be supine or lateral or prone position. If it is supine, I'll go with an LMA because the procedure will not take more than 1 hour. Or if it is prone position, I will secure the airway with an endotracheal tube. Uh, the pre-op assessment, the child is to be seen with the mother preferably, and the mother, we should ask about the antenatal history and the birth history. Any coexisting condition associated with this CTEV should be asked, like cerebral palsy or any other cardiorespiratory diseases. And if any previous anesthetic charts is available, we have to review it. Starvation period, if it is associated with other complex comorbidities, there can be chances of delayed gastric emptying. Examination, we have to look for a good IV access, airway management, and airway management. Investigations, if operative procedures are planned, we'll go for a full blood count and blood grouping and matching. Um, Coming to pre-op fasting regulation, clear liquid for 2 hours, breast milk for 4 hours, infant formula for 6 hours, and solids for 8 hours. Uh, since here it's a 9-month-old baby, parental anxiety will be there. It can be minimized by giving pre-med, midazolam 0.5 milligram per kg, 20 to 30 minutes prior to induction. If there is no IV access, I will go with inhalational. I will go ahead with induction with inhalational sevoflurane with nitrous plus oxygen. If IV access is present, I'll go directly with induction with propofol 2 to 4 milligram per kg. And airway management, as I said before, if it is an LMA, the size of the LMA, because my the expected weight of the child is 9 kg, I'll go with two size LMA, or ET tube is 3.5 and 4, and the depth of insertion of the ET tube will be at 10 centimeter. All ECG, all the standard ASA monitors are mandatory. Maintenance of the surgery is with sevoflurane with fentanyl 2 mics per kg plus short-acting neuromuscular blockade can be used, atracurium versus cetracurium. If the baby is in prone position, we have to avoid the pressure or nerve injuries. Important concern associated with lower limb surgeries is the tourniquet issues. Um, the widest possible cuff should be used. The proximal part, the tourniquet should be applied in the proximal part at the greatest circumference because to prevent the nerve injury. And the limb should be well accentuated by elevation, uh, uh, limb elevation, and it should be applied with adequate padding. The tourniquet should always be inflated to 50 millimeter of mercury above the limb occlusion pressure. In upper limb, it is usually 155 to 190 millimeter of mercury. Lower limb is 140 to 250 millimeter of mercury. And the tourniquet time should be minimized. We have to alarm the surgeon at 1 hour of the tourniquet time, and we have to monitor the heart rate and the BP after and during the deflation. Um, because this occlusion will lead to progressive cellular hypoxia and the accumulation of metabolites, which later after deflation leads to release of the metabolites, which causes a decrease in systemic vascular resistance and hypotension. Post-op management will be multimodal analgesia. If multimodal analgesia with oral or IV analgesics, paracetamol 20 milligram per kg, and uh, with or without opioids and good hydration. Yes. Over, sir. Yes, sir.
What about the use of suppositories in this child? 9 months old. Paracetamol suppositories are you using in your
Yes,
hospital?
yes, sir. We are using
So that is
diclofenac
one
and
option. What
paracetamol.
about caudal? Caudal block.
Yes, sir. I forgot to mention.
So these are all also the methods of doing that. So you can classify this answer into challenges due to pediatric anesthesia. Always I have told you, whenever you are given a clinical scenario like a 9 months old child coming for such and such procedure, then you can classify your answer into the challenges of managing this case falls into two categories. One is challenges of pediatric anesthesia, 9 months old baby. So 9 months old baby, will it have anxiety of separation
Yes, sir.
or stranger anxiety?
Stranger anxiety. 9
It
months.
will be there. More than 4 5 months, it will definitely have stranger anxiety.
Yes, sir.
So, as you rightly said, IV access. Usually, these children are all very chubby. All the children I have seen in practice who have congenital anomalies, they are petted more and fed more. So, they are all very chubby and overweight for their age. And so, IV access will be a difficult challenge. And starvation, of course, the common question in the exam, they will ask you about what are all the restrictions, 6 hours, 4 hours, 2 hours. And as you rightly said, this surgery can be conservatively treated with plaster application in the earlier stages. And because it is diagnosed at birth, it is a congenital deformity, which will be seen right at the time of birth. So because the tissues are all quite supple, most of the time it can be managed with the plaster application, plaster application. You know the name of person who um, advocated this plaster application to correct the deformity? No idea?
Mm.
Okay, it's all orthopedic Ponseti, the person's
Poncetic.
orthopedic
Yes.
Ponseti certification. And Pirani is the person who classified the various types of this clubfoot. Okay, and so you have to include that also. So the second half of the question, you can say the challenges due to the surgery. So first half is challenges of pediatric anesthesia, where you can enumerate all the common problems like airway management, the IV access difficulty, separation anxiety, starvation guidelines, all that can be mentioned in the first half. Coming to the second half of surgical management, as you rightly said, it can be done in either supine, lateral, or prone position. And in my experience, the surgeons prefer only supine or lateral.
Yes.
Do not ask for prone position because they can release the soft tissue much easier in the lateral or supine position because the incision is usually in the below the medial malleolus extending onto the foot. So if it is an extensive soft tissue release and correction, they usually prefer only supine and lateral at the most, and not only for tender case. They usually prefer to have the prone position, and that too, as you rightly said, can be done as a daycare procedure. What is called the subcutaneous stenotomy can be done. No major incision will be there. A 11 blade they can make a nick and then extend, break the tender place and correct the deformity. So I will just share the screen for you.